So, good morning to all of you. Today we are going to start with the mistakes and errors in minimal access surgery. Mistakes and errors are integral part of the human behavior. We do mistake every day. It is impossible that you will not do mistake. Irrespective of all the training, all the skill, you have to do the mistakes. You eat every day, but you do mistake, you bite your tongue. You walk always, but sometimes you put your foot at wrong place and you fall. People are laughing. So mistake is one of the important part of the human behavior. It is estimated that every day $1 billion loss of revenue is there. Every day $1 billion loss of revenue due to human error all over the world, including all the countries. So, concept and mindset of the human mistake, that any mistake which you will do, any error or mistake which you will do, it has two outcomes. Either there will be consequences or there will be no consequences. No consequences doesn't mean that you didn't do the mistake. Just like suppose you are driving a car and for a moment you were sleeping. Suddenly you awake and you will say, oh my God, I was sleeping, it's very bad. But you will see 90% of the time nothing happened. You were okay, everything was going straight. And you were saved by the God. That is called near misses. Just you were about to miss, but you were saved. So 90% of all the mistake, fortunately, are near misses. 10% has consequences. And in that 10%, 90% has only complication and 10% has catastrophe. So total 1% is catastrophe. Means you were driving a car and suddenly you hit some other car, you break your glasses, you break your mirror or bumper. That is complication. You have a discussion with the other car owner and ultimately you will give some money, it will be settled. But there may be catastrophe that you will hit someone and there will be irreversible damage, like he will become handicapped or he will be killed. That is called catastrophe. So every mistake which we do has 1% catastrophe. That's the reason Arthur L. Bloomfield, a famous surgeon, has told that there are some patients whom we cannot help, but there are none whom we cannot harm. And in laparoscopy you can harm anyone. Sometimes we cannot help, completely frozen pelvis, complete intrahepatic gallbladder, and you enter inside and you will say that not possible, and you will open. And there is no harm in that. But sometimes even a simple surgery, we can perforate the aorta or bowel. So a skilled surgeon, safer surgery. Medical error is the third most leading cause of the death in the world. Already I have told you before, during advantage and disadvantage, it was published in British Medical Journal. Heart disease is first, cancer is second, and third is medical error. Do you know in that they are not considering, not counting the medical error not recorded on the US death certificate. This is only US death certificate data. If you will include all together, which is not reported as a death certificate, then it is much more. So, HRA is applicable in all the high risk industry. And now it is implemented in minimal access surgery. What is HRA? HRA means Human Reliability Analysis. This is a new concept which has been introduced in minimal access surgery, MAS. HRA is already applicable for more than 2 decades in the high risk industry like aviation industry, nuclear industry, satellite industry and cloning industry. Because there is no any scope of the human error in this industry. Aviation industry, one human error can lead to the death of hundreds of people. So human reliability must be analyzed. HRA is a team there. Because there is no scope of error. If error is there, human error is there, suppose aircraft is in the sky and then something happened, everybody will be killed. Nuclear industry, there is no scope of human error. You must have remembered Chernobyl incidents in Russia, where millions of people were affected and still they are affected. So it was a human error. And one bear has entered inside the nuclear reactor plant. Bhalu andar ghus gaya. And the bar was not good, and then it started doing some activities. And due to that, some people draw the attention, human error happens, and this mistake happened. Satellite industry, one human error can lead to the millions of people. Once upon a time, a sky lab was going on the universe. It could not reach, it started coming back. Whole world was panic where it will fall. But luckily it entered into sea. So, saved by the God. Cloning industry, it is reported that by year 2050, this will completely spoil the humanity. It has a capacity to completely destroy the humanity. You will be very surprised that some of the scientists are still, this is illegal, but still they are making human clone. And just in some unknown islands, they are already preparing the human clone. And just by changing some of the sequences of the gene, it is possible to make a superhuman. It is just little genetic engineering is required. And you can understand that just by changing the gene, it is possible to make a 50 times more physically a strong person than us, and 100 times more IQ it can have. So you can imagine a world where you are walking and by the side of you 50 feet tall person is walking and he is very super intelligent, you will see him like that, he will see you like inferior quality. And they have coined a name for that also. Those are called technosapien. Technosapien. They are preparing it for the battlefield, for the war, technosapien. And those technosapien will be superhuman. And for them we are homo sapien. We are inferior. So they will use us as a pig to learn laparoscopy, because for them we are nothing more than that. So this is cloning. It is dangerous. But question is, why they have put minimal access surgery? Why minimal access surgery under HRA? Under HRA, open surgery is not there. Only minimal access surgery. If you will go United Kingdom Medical Human Reliability Analysis, in the Google if you will type, UK MHRA is a team. But it is only taking care of minimal access surgery. Why? The reason is that data capture is only possible in minimal access surgery. Open surgery is not under HRA. Data capture is only possible in minimal access surgery. Because without data, your reliability cannot be assessed. Like aviation industry, inside the aircraft there is a black box. It is mandatory in every aeroplane. And if anything happens, crash, then they retrieve the black box. And by retrieving the black box, they can find it out what was the cause of this accident. It was a terrorist attack or technical problem or pilot mistake or some passenger has done some nuisance, and they will find it out. So data is there. Nuclear industry, each and every corner of all the nuclear reactor is under CCTV, satellite surveillance. Satellite surveillance. And there is an organization in the world, global organization, that is taking care of all the, and it is necessary that in any war, these nuclear reactors should not be destroyed. Satellite industry similarly, it is under CCTV surveillance. Cloning industry, it is illegal, and it is estimated that a cloning industry must be under surveillance. But question is, why minimal access surgery? The answer is same, the data capture is available. Whenever anything goes wrong, they will ask for the video. In open surgery, they will only ask your document, and your document should be correct. That's all. You can make a nice story in your OT note. During surgery, you have cut ureter. You can make a beautiful story that ureter was fully adhered with all surrounding tissues, and during this separation, inadvertently, ureter was cut out. But in laparoscopy, this story will not work, because they will ask you that can you give the video. And just by seeing the video, they can find out it was direct coupling, capillary coupling, insulation failure, overshooting, misinterpretation of anatomy. That's why it is under minimal access surgery, under HRA. And you will be surprised, every day 200 cases are filed against the doctors. Those are case rows, 200 cases every day, alone in India, 200 cases. You know, it is estimated that if you will do one surgery every day, then in 5 years, one medical legal will happen. If you will perform one surgery every day, then in 5 years, one medical legal will happen. You cannot protect yourself. It will happen. There are only two ways. One way is to do your own HRA. Another way is you stop doing surgery. But stop doing you cannot do, because you have spent your whole life to learn the surgery. And it is a big problem. All over world it is emerging. Court tells doctors to pay, and man moves court against doc. So $1 million question is that are we prepared? It is a very strange profession where you have to serve other and protect yourself. What is this? None of the profession of the world is like that, where you are serving other and protecting yourself. India has launched Chandrayaan 2. And when our Prime Minister was watching live, sitting inside the control room, and it failed. It could not reach. Chandrayaan 3 was successful, Chandrayaan 2 failed. Once it failed, our chief scientist, he was crying, virtually weeping with the tears, crying. Our Prime Minister has hugged him and consoled, don't worry, next time we will be successful. If you will kill your patient, husband of patient will not hug you. Don't worry, I will bring my second wife. And then you will be successful. It will not going to work. It will be a big problem. Cop will come. Judge will ask you in the court. You have to prepare for that. We are considered as a criminal if anything mistake happens. So, you have to serve other and protect yourself. So for that, you should do your own HRA, human reliabilities. And if you will do our own HRA, then chances are less that you will have medical legal. For that, we should see some literature, some book, that what they say. There is a very big surgeon, Rasmussen. He has given human error model in laparoscopy. That is called Rasmussen's model. According to Rasmussen's model, there are 3 levels of human error in laparoscopy: a skill-based level, rule-based level, and knowledge base level. There are three levels. You can do your mistake in any level. A skill based level means learning curve. Always remember, laparoscopy is not a specialization, it's a skill. And a skill based level human error is the first human error in laparoscopy, and a skill has always a shape of S. This is learning curve is S shaped. ये ऐसे होता है learning curve. Always S shaped. Initially it goes down. When you will start learning laparoscopy, initially it is frustrating. You will feel like यार ये तो बड़ा मुश्किल है, it's very difficult. I don't know I will be able to perform or not, and how will be my practice, how I will develop. That is obvious, everybody has this. This is going down. This is not only for laparoscopy. Even if I will give you a guitar, and then you will try, and then you will see, Bapre, it is not possible, I cannot do that, it's very difficult. But if you will start playing one song, even half of the one song, then you have a very fast rise. So initially when beginners, whatever they do, their 50% of the task has a error. This is Rasmussen's model has proved it. And it doesn't mean, error doesn't mean complication. Error means you are doing and it has a mistake. Like you are putting a trocar and your finger is not pointing towards the tip of the trocar, it was bent, that is mistake. But it will not necessarily, it will convert into complication. So 50% of the task has an error. Once you do 50 cases, then it decreases to 25, in 125. Once you do 100 cases, it go to only 5, and after 200 cases, 1 or 2 mistake will be there in 100 tasks. So it decreases and your learning curve increases. But after 200 again it increases and learning curve decreases. Why? Because of one reason is that you have a age. Age factor is very important in laparoscopy. After age of 70 and plus, then your skill will decrease. And you have to take retirement in laparoscopy. Because every skill has one level of skill. Like that's why, the cricketers, they retire at certain age. Footballer, they retire because उनको लग जाता है कि now my skill will deteriorate. And that goes down. And second reason of going down is that you start taking complicated cases. Because initially you are choosy, and after getting a certain experience, difficult cases will keep on coming in your practice. And that goes down. So this is a skill-based level. And remember, a skill-based level you have to practice your own. Nobody can develop your skill. And a skill development is always offline. And for that, America has done a beautiful job, that they have started one FLS program. That is FLS. FLS, SAGES and EAES both has started. This is called Fundamentals of Laparoscopic Surgery, FLS program. It is mandatory and it is a comprehensive web-based education module for laparoscopic surgery. It is by all, by SAGES, ACS and Obstetric and Gynecology American Board. So without getting a FLS certificate, you are not allowed to enter into operation theatre. You must have to clear this program, and they have didactic content, they have testing, and they have the registry, and you have to take in registry and register yourself. Once you enter into the operation theatre, they will ask, these are the module, pneumoperitoneal module, laparoscopic suturing module, a skill learning module, these are all module, and these all modules you have to finish. Without taking, and all the training institute, even in our institute in Orlando, we are giving FLS certificate, clearance of FLS program. That is mandatory. Without FLS clearance, they don't allow you even to enter into operation theatre to observe the cases. And why they are putting initially? Initially they increase to play the video game. And their training starts with the video game. And video game has a lot of importance in laparoscopic surgery. You can see these all are the literatures where it is showing the benefit of being a video gamer in laparoscopic surgery. This is all, does playing video game improve? Effect of playing video game in laparoscopy. So it is very important that you should start playing the video games. And one of the game which is important and must play is the Nintendo. Nintendo zarur play karna hai. And this is Nintendo game. And it is already reported that if you play this game, your performance will improve. It is by the ACS, American company.
About more than 20 years, and it is still struggling with one of the major problems we are encountering with in the beginning. We are a sort of combination where we are at the moment with developing this game. We cooperate between the University Hospital and another hospital in India where we're software developers for Xundor games, and we joined up to produce the company called Cutting Edge. So it's all about laparoscopy. Laparoscopy is around for a very, very long time now, and we are still struggling with the same problem. So the problem with laparoscopy is there are many problems. We're working with long tools, and we introduce a sort of port in the abdominal or in the thoracic wall, and through that port we introduced instruments. The problem is that from there on it becomes a little bit clumsy and difficult, because what is happening, all your movements are reversed. We call it the fulcrum effect. So you introduce an instrument, and if you want to move the tip to the left, you have to move the handle to the right, and vice versa. So that makes it not intuitive for many users. The other problem there is that you're working with 2D screens, so you have a complete loss of depth perception.
So what they have done,
problem. And the third problem,
they have done that they have, this is, Google has prepared for surgeons one Nintendo. And this Nintendo game they are demonstrating, and this game has a cognitive skill development. Like here you can see, this is the game going on, and you have the instrument like laparoscopy, and you have to catch this, and then you have to pick up, and you have to hold it and again drop at other places. And why this is? Because your cognitive skill will develop. Your reflex will develop, your introcei lumbricals movement will become defined, and then you can develop your skill. So laparoscopy first start with your playing a video game, and then you will have some cognitive effect. After that, you should have the different type of endotrainer. If you will put in the Google that making laparoscopic endotrainer, then you have hundreds of videos given by your seniors. These all are build your own endotrainer. Hundreds of people has given how to make endotrainer and how to do exercises. Hundreds and hundreds of people has contributed their skill, how they developed. Let us take any one of them, and they will demonstrate you how to, like here, we will see he is demonstrating how to make a endotrainer.
Hi guys. Several factors led to the development of simulation in laparoscopic surgery. Reduced working hours, cost of theatre time, focus on medical errors, and the ethics of learning skills on patients are the most important factors. Essentially, and other trainer. Act on the household, make sure they're well away from you. Surfaces from the roof and two sides. I'm securing all the horizontal piece of cardboard such that the other two pyramids. The position angle used British Journal of Surgery in 1997 by not degree. I want to use these two numbers, a manipulation angle of 60 degrees and a camera to target distance of 7. The two retinas of the two instruments inserted into the box are equal to each other. Lengths of both 18 cm, 12 20 plus 20 plus 20 equals 60.
A skill, if you will ask anyone who is doing good laparoscopic surgery, he will not tell you the truth because he doesn't want you to become good in laparoscopy. So if you will ask him, he will say, "मैं तो बचपन से ही ऐसा ही हूँ, I am like that." But he has spent hundreds and hundreds of hours in the lab and to develop the skill, because a skill development cannot be done on the patient. If you think that if I will develop my skill on the patient, then be ready for paying cost of that. Your reputation and your money both will be lost, because you will do more mistake, your outcome of the surgery will not be good, your reputation will be lost, and if something goes wrong, you have to pay for that. So there is no shortcut of a skill. No shortcut. I am sorry about that many laparoscopic surgeons, they think that they will start cutting over the patient. That is how they have learned open surgery. And they have the same impression here in laparoscopy कि ओपन में कहाँ कुछ किया था हम लोगों ने, तो कोई प्रैक्टिस किया नहीं. Open is not a skill. Open, you are tying a knot just like how you are tying your shoelaces. Open, you are dissecting the things just like how you are cutting your cloth. You are cutting the abdomen. But here laparoscopy, you have a completely instrument dependent surgery and cognitive surgery. So a skill development. Every week, at least half an hour, twice a week, you must do endotrainer practices. Different tasks you can do. Hundreds of tasks are there on the YouTube. And you complete all your tasks. I guarantee you that one day your hand will be so good that people will keep the finger inside the teeth. How good he is. And that is very important, a skill-based level. Second is rule-based level. Misinterpretation of good rules and application of bad rules. What happened? We start avoiding the good rules. Because once we start doing surgery, then we start taking shortcuts. Just like many people, they directly put the trocar. Many people, they don't do irrigation suction hanging drop test. Many people, they don't respect the quadromanometric indicator of insufflator. Many people, they don't respect the energy sources. I will show you those mistakes later in this slide. And we say that it's okay, it works. Never. You know, bad habit is ready to entering into your practice as soon as you will start avoiding the good rules. Just like a traffic rules, a driver who is not respecting the traffic rules, not respecting the speed limit, not respecting the lights, red light, not respecting the honking, not respecting the overtaking, he will do mistake. Third is knowledge base level. Incorrect knowledge or incomplete knowledge. Unfortunately, problem of the knowledge is that in laparoscopy, knowledge is outdating only in 4 years. Whatever you are learning today, after 4 years, it is obsolete. Completely obsolete. It doesn't have any value. In old era, in our one generation back, in our father's time, whatever you learned, it was existing for 20 years. It will work. Today not. Because all the camera which you have today, after 4 years, it is obsolete. New camera comes. Like ICG camera is now obsolete. Now new camera, Doppler cameras are coming. Doppler sensing instrument, what it has, that suppose you have coagulated uterine artery and you put your instrument can sense on the screen that still this coagulated artery has a blood flow or not. And if blood is flowing, it will give you the blood flow lining so that you coagulate once more and you can never have any bleeding. So inside the instrument they are making Doppler probes and which can sense the vessel which is coagulated. So now these will be obsolete, you have to throw it out and buy the new instrument. All the harmonics which you are making today, those are obsolete. All the ligatures are obsolete. Trocars will be obsolete. New generation, within 4 years, robots are obsolete. Within 4 years, new robots, new technology comes. Because technology is, developing so fast. Even if you buy a mobile phone today, after 4 years, you have to throw it. There is no way. You go to your service that it is not working. They will say, what is this you are carrying? Throw it. अब तो क्या सर लेके घूम रहे हो आप ये? It is now, no, company is not making it. Throw it. This is a new iPhone. You must buy. And they will not service it. Company has a stop. End of life. They write end of life. So knowledge base level and incorrect and incomplete knowledge. Now question is how to develop the knowledge. For knowledge you must be 2-3 things you should keep in mind. First thing, that you should be member of some of the societies. So you can join SAGES, you can join American Association of Gynecological Laparoscopy. Already we have given you the link we have shared our username and password of the SAGES or AAGL, and through that you can go, and if you want you can also become member, so that you can create alerts and you can find out the new development. Another is to create Google alert. You should go to Google alert. This is important. And Google alert जा करके आप यहाँ पे you should try to put your all the important your interesting topic. Like today, suppose I am creating. First you should also put your name also. You know what is the advantage of putting your name? That if someone is talking about you, Google will alert you. Because Google is the largest search engine of the world. So suppose in Facebook, why Dr. R.K. Misra is rubbish, only making money, doesn't have any. So if you will take it like that, Google will inform you that someone is talking about you. Of course, it may be the duplicate name, maybe, but at least you have a satisfaction that I am not there. So you should put your name, your hospital name also. Someone is talking bad about your hospital, you will come to know. Second important thing, that endometriosis, suppose I want endometriosis, then create alert. Now what happened? Again you make nephrectomy. Suppose anything, create alert. What happened? Next time, whenever any article of nephrectomy is published, Google will send you one email. New articles. and exactly same way, IVF, your interest, ovum pickup or anything, and that Google will send to your email account automatically at once in a week only. It will not send you every day, and there will be link, and you click on the link and then it will go to you. Another way is that you should get a membership of High Wire Press. High Wire Press is from Stanford University. Here also you can create alert. This is fortunately free, and it will give you a scholastic artery. High Wire Press काफ़ी मज़ेदार है, British Medical Journal and all is free here. This is from Stanford University, and you can create your account and you can get get all the journals. And here also, after creating your account, you can create alerts. So any scholarist article will come, it will do. Another way is to go to the Google Scholar. Google Scholar. In Google Scholar, you go and type laparoscopic surgeon, and your favorite laparoscopic surgeon jitna jitna hai in gynae and all, you should try to immediately, like suppose I am getting, suppose laparoscopic surgeon, suppose I want George Hanna. This is George Hanna. Sorry, he is my teacher also, and he was with me also. So George Hanna, Professor of Surgery, Imperial College London, and you will follow. That's all. What follow? New article. Once his new article is there, you will be informed by the Google that this is his new article, and you have to type your email here, and then it will do the job. After that, you can follow Professor Barsi, Professor Aradarji, whatever you want, and if you like, you can follow me also. Then it will give you all my articles will be available to you when it comes the new. So this is the most important thing, is the journal and articles. After that, YouTube. In YouTube, how to search, this we do mistake. Suppose you have to do, suppose laparoscopic myomectomy. When we type just laparoscopic myomectomy, this will come like that. This will not work. These are the advertisement by the company here. So what you have to do, you have to go filter. Always use filter. In the filter, first you put HD. That is important. HD kar liya. After that, again filter. Over 20 minutes. You know, within 4 minutes or less than 4 minutes, myomectomy is not possible. And if you see those videos, it is wastage of time, or it is advertisement, or patient testimonial. So you put over 20 minutes. After that, you should try to put today or last year or this year. If you are a regular viewer, then last year, this year or today. If you are not regular viewer, then you can leave it and see all these surgeries are there. Unfortunately, most will be mine, but if it is not mine, then also you can see other people's also. Like this is not mine, but you can see. So this is how, this is good. Prashant Mangeshkar, he is putting his video, and he is, but this is lecture. Lecture has a good thing, but if you have the operative procedure, then it is better. So this is important, that how to search in the Google, because directly if you will go to the Google, it won't give you the much information. So SAGES, EAES, and then AAGL and other organization, knowledge based level, ये आपको बढ़ाना पड़ेगा knowledge, and new technology you should must learn. So level of human error, skill based level, rule based level, knowledge based level. Now categories of human error. There are two categories of human error. One is related to performance of frontline operator, and another is latent hidden within the system. Related to performance of frontline operator, effect is immediate. Like suppose I did some mistake, I cut the ureter or I cut the CBD, effect is immediate. And that is not a big problem. Big problem is accident is waiting to happen and latent hidden within the system. Means system पे आपका control नहीं है. Remember, in laparoscopy only a skill development, knowledge development and the rule development will not make you a good laparoscopic surgeon. You have to become a good manager also, and you have to keep a control over your system. System control is very, very important. Like Sages and Aaron has given a system checklist. I will show you. If you go to your member area, then you have a system checklist. That system checklist is given by Sages and Aaron. So where it is, I will show you. You go, and here in the first page itself, this checklist is there, and this is the checklist here. This is system checklist. This is minimally invasive surgery safety checklist. It is made by Society of American Gastrointestinal Endoscopic Surgeon. ये checklist है आपके member area में, it is given. What you should do, you should print it in a A4 size paper and put in the OT. And whenever you start performing any surgery, ask your nurse कि checklist दिखा दो, show me the checklist. A nurse has checked it and she has signed it or not. Remember, if you maintain this checklist, your 50% of the error will be minimized. It will not happen. It is already published data, system checklist. So, after a skill development, knowledge development and rule development, you have to develop system checklist. Just like you might have seen, when you come out of your aircraft, just when you exit, some people, they enter from the back door of the aeroplane with the checklist. Those are called aircraft maintenance engineers. And they have to click all the checklists. Usko click karna hi hai. Every checklist they have to click and sign. What I does, this is same way. First, circulating nurse duty. Surgeon's preference card received, check. If she has received surgeon's preference card or not. Surgeon preference card means suppose I have to go for a hysterectomy today. Nurse will come and she will ask me that, madam, what are your preference instrument please? Can you give me? I will arrange it. You will say yes. Why? You will say that I want Mangeshkar uterine manipulated. I want Ligashore Atlas. I don't want Ligashore Maryland. I want Ligashore Atlas. And I want harmonic ace, not harmonic shear. I want harmonic ace. And then I want this left side atraumatic grasper. And one trocar 10 mm, 2 5 mm, one this, one that. This is, and then it is okay. Do you know, even simple, if you see, like a series of different type. ठीक अभी थोड़ा टाइम अभी शुरू ही किए. So Ligashore has different instrument. Ligashore Atlas, उसमें चौड़ा jaw होता है, it's a blunt jaw. And Ligashore Maryland has a slight pointed jaw. And both has different functionality. If you will use one and another, it has a different functionality. Ligashore Atlas, ये Atlas है Ligashore. See this, ये इसका jaw ऐसा होता है, completely blunt. This is called Ligashore Atlas. And Ligashore Maryland is different. It has a pointed. ये देखिए इसका pointed है एकदम, just completely pointed tip. And you know, if you will use XP Maryland, इसको बोलते हैं Ligashore. And if you have a habit of using Ligashore Atlas, and I will give you Ligashore Maryland, and with that you start separating the bladder, you will perforate the bladder. Because pointed beak like it has a tip. तो आप उसको perforate कर देंगे, you will perforate and you will not know also why you have perforated. Like a harmonic ace and harmonic shear has a different shape. If you are working with the Mangeshkar, you try and manipulate it, and first time someone will give you Marwa or Rumi, you will mess up. So it is very important that this preference card should be checked. So surgeon's preference card. After that, OR table position, correct orientation, weight capacity, bean bag, mattress, table accessory, spreader bar, leg support, footboard, position of fluoroscopy if it is needed, power sources connected to room, CO2 cylinder, check the CO2 volume, check the CO2 pressure, check the flow, backup cylinder is available or not, range of opening the cylinder is there or not, filter is changed or not, tubing is completely cleaned or not. Simple things are written that make a big difference. Even for various units, check the plunger, check the spring action. A spring action is not working because during it was not clean and some clot were there. Blunt tip will go back and it will never come in front, and then it will perforate the bowel because the spring was not working. So nurse has a duty that check the spring, check the plunger, flush the needle with the start cup and click, I have flushed or not. Simple things are there. Do you know, system is so important which we are not following generally. That is which make your, if you go to 5-star hotel, a 7-star hotel, then even in the bathroom they have a system checklist. And it is necessary that cleaner will come and he will check everything. Open the stopcock, check the flush, check the shower, check the washer, check the handles, everything check. Our is what? If it is not working, you will call someone and then he will fix it. This should not happen. So, system control. So, this is called latent hidden within the system. Like suppose you have not taken care of and someone has given you the instrument which has insulation failure, it will perforate the bowel, and then after second day patient come with the perforation, and you cannot blame the system. You cannot say nurse has not checked it, because this is your responsibility to see that system checklist is proper or not. Court will not tell that nurse should be fined because she has not checked the instrument. Any court has ever not fined the nurse. You will be fined because you are the captain of the team and this is your responsibility. So this is called regions model. If you want to control the laparoscopic skill, and then system should be under your control. We are only interested to see the front of the trolley. You should always try to go behind the trolley and see all the wires are connected. You know, if you have a 4K camera and it is attached with SVD or composite cable, your video will not come good. Or suppose they have used HDMI, they should use DVI, then also it will not be good. So this is the categories of human error. Now if you want to become a reliable surgeon, you have to embrace 3 disciplines. As I always from first day I am telling, ergonomics, task analysis and engineering. These are the only 3 disciplines which make you perfect laparoscopic surgeon. Ergonomics, as you know, very important, interface between man and machine. And we should be always going behind the camera, not only in front of the camera. Some of the ergonomic point which we have noticed, that OT table height is very important. It should be 64 to 77 centimeter from the floor or 0.49 into the height of the surgeon, so that your instrument handle should be at the level of your elbow. Whatever you do in your day-to-day life, you have only better performance if hand is at the level of elbow. If it is up and your arm is abducted, your performance will be affected. Then always try to make the manipulation angle as near as possible to the 60 degree. Always try to follow the baseball diamond concept, so that a baseball field has to be formed over the abdomen of the patient. Always try to keep the elevation angle 15 to 30 degree. If it is more than 45, you will be in trouble, and less than 15, you will be in trouble. More than 45, your hand will come at the level of your shoulder, and more than 15, your handle will touch the body of the patient, and you cannot perform the surgery. After that, prevent losing instrument. If instrument is lost, Don't try to find out by hit and trial, by just finding hit and trial. What we should do, first we should pull the telescope out, after that take the instrument out and make the same elevation angle as the telescope, and 30-degree azimuth angle you will get the tip. If you will blindly try to find it out, you will perforate somewhere. Coaxial alignment must be maintained. Eye of the surgeon, target of dissection and center of monitor should be in the same axis, so that your neck should not be tilted. After 15-degree tilt, every 5-degree decreases your 5% performance. This study Tübingen University they did with the infrared sensors. After that, resting eye should see 10 to 15 degree down. So you should keep the monitor in such a way that it should be little below your eye level. If you have a student, you can keep the extra monitors, but the main monitor which you are seeing should see you down. This is a resting oculomotor muscle. If you will see it up, you will have eyeball degradation. That's why when you go to the movie theater, the expensive tickets are above the screen level, so that your resting eye should see little down, and then your performance will improve. After that, your distance of the monitor from your eye should be 5 times to the diagonal length of monitor screen. If you are using 14-inch monitor, then it should be 70 inch away from your eye, and vice versa. If you are using 21 inch, then 105 inch. Bigger monitor you have to keep little away, so that a screen should occupy your entire macula. It should not go out of macula and it should not be inside the macula. Your picture should occupy the entire macula, then only your performance is good. If instead of picture your surrounding is occupying the macula, your performance will deteriorate. Question is why? Because optical illusion develops. Now, number of monitor ideally should be 2, one for you, one for your assistant. If you have only one, then keep it in such a way that more than 15-degree tilt should not be for you as well as your assistant. So more than 15-degree head tilt should not be there. After that, we should try to keep the OT light 20 lux. Lux is a unit of this intensity of the light. You should buy one lux meter. Lux meters are very cheap. They are available hardly little bit. This is called lux meter, and you can buy it in maybe 1000 rupees maximum. Some are cheaper than 1000 also. These are lux meter. So एक खरीद लेंगे, and then you will adjust by the side of the screen, so that dark operation theatre, because if lighted operation theatre, optical illusion develops. So OT light should be 20 lux. Avoid touching the bloody viscera by the tip of the telescope. So if the telescope is become dirty, it will be a problem. So once bleeding is started, don't go bring the telescope near the bloody viscera, and prevent fogging. How to prevent fogging? First way is, and best way is, warming. You should have a flask with the warm water. Warm water means completely warm water, not just 30, 40, 50 degrees centigrade, because you need the warming should go up to the lens. So you can keep one thermos with the heater or any thermos, and you put some sponge inside that, so that lens will not touch the base of the thermos, and then you should put it. Another way is you can buy anti-fogging solution, anti-fogging device, anti-fogging solution. A lot of anti-fogging solutions are available in the market, which you can buy. Anti-fogging laparoscopic solutions, every company is making, Storch is making, the Olympus is making. These are anti-fogging. They will give you one bud, and they will give you, what is this bud for? This bud is to clean the light post. Inside the light post there is a hole, just like how you are cleaning your ear, same way there is a bud. So usme डाल के, and you have to clean, because if your tip of the telescope is cleaned, but this eye post, the light post is dirty and it has a dirt, your image will be bad. Generally nobody cleans it ever. So light post you have to clean it. After that, few drop of a sponge you will put it into this anti-fogging solution and rub it over the telescope and it become completely. Another way of developing the good vision is there is one device that is called flow shield, and this flow shield is available and you can use it for decreasing your fogging, and it doesn't allow the instrument to become dirty also. This is called flow shield, and this flow shield device is available by the many company. One of the American company has started making it first time in the world. After that every company is making. Surgeons should not be compromised with the laparoscopic procedure, and that's why this flow shield device work on vortex barrier technology. Vortex barrier means they have a air curtain. So if you will see here, this is flow shield device, and in this flow shield device you can introduce your telescope, 30 degree, 0 degree, all the telescope can be introduced like that here. And then CO2 will not be attached with the cannula, CO2 attached with this tubing. CO2 of insufflated will attach here, not in the cannula. And then what happened, a CO2 curtain will form in front of the telescope that will never allow to get it fogged. And suppose due to some reason you have touched to the blood or anything, there is a channel for syringing, and you can, this is a flow X fluid, they also give you together, you put it and flush it, and after that it will clean. And do you know it will decrease your 10% of the operative time also, and you have a superior vision, clear vision. So that is called flow shield. This is available in 30 degree as well as 0 degree telescope. It is also available for Da Vinci robot telescope also. So this also is possible to buy. After that, keep telescope STD. If you keep telescope STD, their surgeon will not have eyeball degradation and your performance will be good. And STD and front, you know, telescope is very important. There are three type of camera person. One is bad, another is average, and third is good. So I will show you, suppose this is uterus, and suppose here is a bladder. This is the bladder, and I have to separate the bladder. I have opened already anterior and posterior leaf. Now uterus is retroverted and I want to separate. To separate, I am using a blunt instrument and dissecting like that. I am separating with the flageolet or blunt instrument. I am pushing the bladder down. I am pushing the bladder down. And here is the view. This is the view. Like this is the monitor. Now, a bad camera person will show you like this. Average will show you like this. And the good will show you like this. You can very easily understand with simple example. Suppose you have a party, you called your best friend to come for dinner at your home. And when he came at night, then power failed. Lift is not working. He is climbing in the dark on the stair. And he is your friend. You are on the second floor. He is climbing anyhow difficulty in the dark. Then you have a torch. And from the top you will say, oh come, I am giving you the torch, come. And you can put the torch three ways. One way is put the light of the torch, a stair behind him. Means he has climbed, just a step behind. That means you want he should go. Another way is to put the light of the torch on the step where he is standing. It is not necessary because he knows where he is standing. And the third is you can put the light a step ahead. Which one you will prefer? A step ahead. So if someone will keep the telescope and he will keep the telescope here, the camera like this here, then what you will do? You are separating bladder down and he is showing you fundus of the uterus. You will get frustrated. You will feel like hitting him. At least you can see, dekho, kuch mat karo, you don't do anything, at least keep my tip of the instrument in the center of a screen. That is average, that is. And better is keep it this way. Why? He want that overshooting should not be towards the bladder, because your direction of movement is towards the bladder, so overshooting should not be towards the bladder. Exactly same way, if you are separating the peritoneum in this direction and your direction of incision is here, you are going like cut like that, and suppose this is your instrument, here is the instrument. A good camera person will keep the tissue front in your vision, a step ahead. A bad ऐसे दिखाएगा, मन करेगा एक थप्पड़ मारें इसको, because your tip is here and you don't have any idea what is in front of me, because your direction is going towards the tip ring. You are opening the peritoneum and there is no idea that what is in front. And a good will show you like this, because he know what is your next step, and he will make your surgery faster and safer. So always remember that keep telescope steady and keep the step ahead. Keep panoramic when surgeon is inactive. Suppose surgeon is not performing the surgery, he is inactive. Inactive means, in robotic surgery there is a great control. We will learn on 17th the Da Vinci and the Mantra, both the robot will demonstrate you that if your eye is not seeing the screen, if your eye is seeing here, robot will statue all the instrument. It will freeze all the instrument, वो freeze हो जाता है. Or in Da Vinci, if your eye is not inside the console, if you take out of the console, all the instrument get locked. Why? Because suppose you are not seeing, and at that time any instrument moves, it is dangerous. It can pierce iliac vessel, it can perforate rectum. So exactly same way in laparoscopy, whenever you are inactive, suppose you are tying a knot or you are busy changing the instrument and you are not looking at the screen, when surgeon is inactive, this is the responsibility of camera person, so he should have a panoramic vision and he should also not see what surgeon is doing. His eye should be on the screen so that panoramically he can see that all the other instruments are at correct position. Because you are tying a knot and he has also left the telescope and he is seeing how you are tying the knot, and you go with the knot inside and you don't have a structure, already it is avulged. Tube is no more there, appendix is already break. So it is important that keep panoramic and steady whenever surgeon is inactive. So maintenance of the endoscopic eye is very important. Then mirror image must be avoided. Vision axis and action axis should never ever be opposite to each other. In any circumstances, your azimuth angle should never be more than 90 degree. Otherwise, you cannot perform any surgery. If azimuth angle is 30 degree either side, then it is called contralateral. And if 30 and 60 on the same side, then it is called ipsilateral. Like suppose this is the instrument, this is the patient, and here this is one here, then this is called contralateral. And one here, then it is called ipsilateral. In contralateral, what is the azimuth angle? 30. In ipsi, one is 30 and another is 60. But if it is more than 90, you cannot operate, because it will start vision axis and action axis inverted view. You move right, it will move left. So if it happens, immediately you should recognize that, oh, I have inverted view, and change your port position. Or you change your telescope, or you use 5 mm telescope in another port, and your problem will be solved. So mirror image should not be there. After that, sectorization. Sectorization means ipsilateral, then at least 30 degree manipulation angle is must. Less than 30 degree, it will do shorting. So sectorization is sometime performed. Remember, in pediatric surgery, sectorization is never done. Always contralateral port position. उसमें उतना जगह ही नहीं है कि आप नहीं कर सकते. If suppose you have a small child and you want appendectomy, one port here, one port right hypochondrium, one port left iliac fossa. You cannot put suprapubic, you will perforate the bladder. But in adult it is performed, and only for mobile organ it is performed, like in gynae surgery. And gynae also, if it is a mobile, not for radical hysterectomy, not for lymphadenectomy. And in general surgery, only done in the appendectomy and fuse surgery. So this is sectorization, but in sectorization also 30-degree manipulation angle is must. Wrong port position is a big problem. See here, telescope is here, and surgeon has put one port right iliac fossa, one port left iliac fossa. So this angle is 90, this is 180. This azimuth angle, this is telescope. So this azimuth angle is 90, this is 180. And now see what will happen. Here there is a ileocolic band, and he is trying to coagulate. This is cecum and ileum. And see, one instrument is in right iliac fossa, one. First mistake, swording. This is ligature atlas. This is a beautiful ligature, 10 mm ligature atlas. So first step is he is swording. Second step, problem, he is stretching this is swording and stretching the structure which you want to coagulate. Remember, any structure which you want to coagulate must not be stretched. Otherwise it will never seal. It should be relaxed. Either uterine artery or cystic artery or renal artery, splenic artery. So he is stretching, and a stretch condition he is doing, and we can see bleeding started. Now this bleeder is still saying, I am here, please, someone will catch me. Because bleeder is very good and it's artery, you can catch it, but he is helpless because he has a mirror image. So his other instrument is not reaching there because he is not having the ergonomics correct. So problem is what? Problem is ergonomics. And again another, we can see here surgeon has done a wrong port position, and see it is he has hit the aorta. देखिए hit हो गया वहाँ, and it's bulging. I am repeating this video. It is hit. Why? Because finger was not put towards the tip, and see this bulge is increasing. Again I will repeat this video. See, it was hit there, and blood will, see again I am repeating, and see it has hit. With a fraction of second, बहुत गौर से देखिएगा तब पता चलेगा. It's hit. And within fraction of second it is hit. A telescope was also not showing in front. It was showing here initially. So see, telescope was showing here, and see it is already hit here. And now you will not see blood in the abdomen. Why? Any retroperitoneal injury, always blood collected in the retroperitoneum, and it's already aorta is hit, and it's bulging and increasing, bulging. So this is what? Again same way, your tip of the index finger was not pointed, and always to introduce the telescope, your finger should rotate. You should apply less force, more rotatory movement. If you will not do rotatory movements, bulging, and now you have to convert. This is not, the blood will not come in the abdomen. Any retroperitoneal injury, blood collected, and see immediately BP will loss. So immediately you have to convert, then open the peritoneum and repair. Again we can see here there is a big hematoma, retroperitoneal hematoma, because your optical trocar has hit and it was perpendicular, and see this big huge hematoma. This is the injury of aorta, and aorta was directly hit, and this is bulge, all bulge around. BP 59/25. Pulse is still maintained because 100% oxygen is given to the patient, and this is, see, and it's entire bulge. You will not see any blood in the abdomen. You will see only the bulge, because all the retroperitoneal aorta or vena cava or iliac vessel injury will show you bulge. The next step is to consider laparotomy immediately. So where is the problem? Problem is ergonomics and task analysis. Wrong technique of putting the port. Remember, in laparoscopy बड़ा mistake नहीं होता है. Bigger mistake doesn't happen. Only the mistake happens in the fundamentals. If your fundamentals are correct, you have not taken a training at correct, and just you have started doing surgery by just seeing other how they do, then the mistake happens. Because basic fundamentals, if you will do the mistake, then it happens. A small mistakes creates a big complications, not the big. Distance between two instruments should never be less than 5 centimeter. Otherwise it will short at the level of abdominal wall also, and some time it create a huge hernia. And most of the time, if you are not repairing it here, surgeon has not closed the port and he has directly pulled the 10 mm port, and you can see entire small bowel is incarcerated into the 10 mm port. And now this is next day of the surgery, patient has obstruction. Again re-laparoscopy was performed, and then it was found that entire small bowel is entering into the port wound. This is port wound, and immediately you have to pull all of them out and then repair. So port closure is must. You should always carry one cobbler's needle or port closure needle, and in all the 10 mm port. Only in the midline here it is cutting the peritoneum and trying to pull this incarcerated bowel. Only midline you may leave it if it is in midline, but on the lateral all the 10 mm port or above. I told you already the percentage of hernia. In 5 mm it is only 0.25%. In 10 mm 0.5 to 2%. In 12 mm 20%, and 15 mm 50% incidence. So now this bowel has come out, and now this is the suture passage which is closing the port. Sometimes the bigger port you should have 2 knot. One will not work like 15 mm. So here 2 knot, one here, 2 knot were taken to close the port. And skin incision will be same, and this wound will come including every port closure. I told you facial closure will not work in laparoscopy. Facial closure is bad. Port closure, full thickness abdominal wall. So this is one and this is second. Here 2 knot we are taken to close the port properly. So port side hernia also can happen. Gesture imprecision should be avoided. Never use large diameter cannula with the small diameter instrument. This is called gesture imprecision. Like sometimes what happens that we have to do morcellation, so initially only we keep a 15 mm port, and we think that we can morcellate it, so why not to bring the 15 mm from the beginning of the surgery, and then from the beginning of the surgery if you make it that much big port, you have a problem, because it will remain loose, and whenever it will touch here it will make class 2 liver, when it will touch here it will make class 3 liver, your precision will be affected. Just like if you have a stool and one of the limb of the stool is short, all 3 are big, then it is called gesture imprecision. So this creates gesture imprecision. So always you should try to use a long reducer, not a top mounted reducer. In the disposable, gesture imprecision happen more, because in disposable there is a top mounted reducer, and that create more gesture. So unnecessarily you should not use 10 mm port. If suppose later I need 10 mm or 15 mm, then from the beginning 10 mm should not be used. In beginning 5 mm, once morcellator is required, then I will enlarge to 15 mm. In the beginning if you use 12 mm, gesture imprecision will happen. After that you should have correct shadow, and to get a correct shadow you should have always light cable up. Already I have told you before that shadow telescope should be used. Always buy a telescope where lens is on the down and light is on the up, because in the older generation telescope is in the middle. Still some Chinese telescopes are available in which the telescope is in the middle, but Storz has taken this technology. This was my original research topic of optimum shadow casting illumination in endoscopic task performance with my professor Sir Alfred Kusheri. So after that telescope is now creating a good shadow. After that engineering part. So this was regarding ergonomics and then engineering. Lack of engineering knowledge is also big problem. So you must know on the back what is CAN bus, what is SAN bus, what is HDMI, what is DVI, what is composite, what is S-video, how to connect camera with your monitor, how to connect camera with the light source. You know, camera is also connected with the light source to give the different automatic leveling. So this is important that you should develop, you should read the manuals of the camera and try to know how it works. Poorly engineered equipment should be avoided. Lack of periodical checkup. Make it a rule that every month, once in a month, you will check all the instrument yourself. Like insulation of all the instrument, then the joints, paraffin oil is given or not, it is rotating properly or not. You are holding in the lab, you might have seen that some of the instrument doesn't rotate with your finger. You have to rotate with your right hand. Then, and that also sometimes doesn't rotate. So it should rotate by the tip of your index finger itself. And if it is not rotating, that means periodical checkup is not done. Paraffin oiling is not done. Faulty power supply is also one big problem. So I will suggest you 3 kVA online UPS you should buy. That is very important. Online UPS 3 kVA, and I will recommend you APC is better company, and it should have inbuilt battery. So 3 kVA online UPS. This is important. Offline UPS you should never use. So APC, this is good, and this is available, and this is APC 3 kVA online UPS. ये आप खरीद लें. What is the advantage? That your instrument life, it is around 50,000 rupees का आएगा, but it will increase your life unlimited. Your laparoscopic camera, harmonic, insufflator, light source will never spoil. Even up to 20 years you will use, it will never spoil. Online UPS and offline UPS, 2 types are there. Offline you never use in laparoscopic instrument. It will immediately make your instrument faulty. Because offline UPS has a cut-off switch, it cut off. And due to that, there will be no sine wave, there will be fluctuation spikes, and that will destroy your camera. Sometimes we don't understand, simple stabilizer or offline UPS we attach. Online UPS, what it does? Online UPS has sine wave. So what it does, that it will never supply your instrument with the main line. It will always supply with your battery, and on the background battery is getting charged. So there is no spike, and your instrument will last for 20 years without any faulty. So faulty power supply is one big problem, especially in developing country. It is not so much in Saudi and other places. It is very good power they have. But in India it is fluctuation and spikes are there that will blow your camera, and those are expensive, lakhs and lakhs rupees you have spent. So one investment in faulty power supply is good, and you should have online UPS 3 kVA, and that will take care of entire trolley, including insufflator, energy sources, everything. Now coming to psychology, laparoscopy is often prejudiced, so we should not be impatient. Patience is the key, especially something goes wrong, some bleeding has started. Over enthusiastic, we should know when to convert. So suppose surgery is not progressing, this is time to convert. Reluctant to training, what happens if 3 times same problem happens? That means you need training. Like suppose you are doing hysterectomy, and one time you try an artist, severely started bleeding. It can happen to anyone. Once in a while it can happen. Cholecystectomy, gallbladder get punctured, cystic artery bleeds. Hernia, you have injured the obturator vessel. It can happen to anyone. We can never expect to perform surgery without encountering some type of adverse situation. But if it is happening regularly 3 times, that means you need training. And for training, what to do? Nothing. You have to find out your task analysis, your steps. Somewhere your steps are wrong. Keeping in mind what we try to do, that in your member area, we have given one, this, update your file and share your file with the faculty. So what you have to do, you have to go to your member area, and after that you can share up to 40 GB file. No Dropbox of the world is giving you that much free space to upload. Even the Google is not giving you more than 5 GB to upload in free account. But here you have the 40,000 MB. This is the username and password. Just you copy and paste, and after that this is your personal Dropbox, and you can submit, and this is Dropbox. So there is 40,000 MB data you can upload, and just nothing is required. Just you go and upload it, and once you upload it, after that it immediately reach to us, and then we will immediately answer. So this is important, and Advantage is that you will, like suppose this video I am uploading, and it is uploaded already, immediately uploaded. I am uploading another video, like suppose this video. This is, and here this video. So these all 5 GB, 10 GB. So what you do, always do whenever you do the surgery, then always try to, this is again upload. So 2 video it is uploaded. After that you can see your uploaded file here. And immediately one email comes to us, and we will come to know that what is your question. And immediately here chatting, one of our staff will be also ready for chatting. So if it is emergency, you can ask him to help. And once it is over, you can delete your file here. So this all file I am deleting. So this is your file with the faculty. You can share your file with the faculty. So what happened, that we will give you some idea. Like suppose you have not lateralized the bladder pillar, and then together with the bladder pillar you were trying to coagulate the uterine artery, it will not coagulate. Or during that traction was more, or it, as I told you, uterine artery takes 9 seconds to get coagulated, and you are applying only 3 seconds, then it will not work. There should be 3 seconds 3 times, then only it will sell. Or during the second time cooking, your tissue was dry, so it has overcooked. You must put some saline so that it should not overcook, otherwise elastin and collagen will burn. Or during that you have suppose you were holding it under cooking, bubbling of water was not visible, and the color of the temperature has, so this way once you learn, problem solved. So in ABCD, C was missing, and you have to find out where is that C. What I am missing, reluctant to training. Remember, nothing is difficult in the world. Only thing is that task analysis we are missing. That missing later you have to find it out. Like ABCD, I am writing ABD, and this is missing. So what is missing? You can try to find out in the Google, seeing other person's video, and then you can realize, oh, he is doing that I am not doing, I will insert, and this is my extra step. Just like in the hysterectomy, just like surgeon's knot, there are 38 steps. And if any one is missing, that means you do the mistake. And if ABCD, if you are writing ABD, then also it is wrong. And if you are writing ADB, then also it is very big wrong, because you have put one before, another ahead. So task analysis, always never be reluctant to training, because we never train, not possible in one life. Till you die, you will keep on learning. So we should never be reluctant to training. Always try to improve, add more executional steps in your surgery. Another bad habit, dependent to others. Sometimes we only work with the other people. In laparoscopy, there is no role of assistant. If you have a habit of depending to other, your own skill will never develop. This habit we learn from open surgery, because in open surgery we have to be dependent to other. Some of the OT assistants are there, they are so good that they make the surgeon perform surgery. In the small cities, there are one OT assistant who go to 3-4 surgeons, and if that OT assistant will not come, they will not do that surgery that day. So we dependent to other. In laparoscopy, your left hand is your assistant, your right hand is surgeon, and everything is your own decision. This is solo program, just like dancing on the floor or singing on the stage. You should never be dependent to other. After that, we should develop our emotional intelligence. IQ is not important in laparoscopy, because it's not a specialization, it's a skill. And for any skill, emotional intelligence is more important. IQ is not so important. So self-awareness, empathy, motivation, self-regulation, and social skill, this is important. You should be very friendly with your team member, and like your assistant who is doing uterine manipulator, your assistant who is holding camera, and then only you can develop. Otherwise, if you will try to become only like if you might have seen in your medical school, that some of very senior surgeons are they are very big administrator and very angry person, Like if he is coming from that road, you will try to change your road, go to the another. You will not directly try to face him because he is so strict, and you are always afraid with your professor because you think that, oh, he is professor, how can I talk to him? Those people who are very angry and very big administrator, their laparoscopic skill can never develop. Why? Because first they have to unlearn and then relearn. And unlearning is very difficult. So what happened, once they start doing laparoscopic surgery, their skill also starts from zero. But they have a prejudice that I am professor, head of the department. And then in that situation, once they do little mistake also, they stop laparoscopy and they not allow the junior also to perform. So that will not work. You have to be very much good with your team, and you should allow, professors should allow youngster to perform surgery. This attitude is not in the developed country. Like if you go to US or UK even, if you are sitting and eating your professor, you are eating burger, even a cleaner will come and he will sit by the side of you. And he is also eating the same burger, and he will say, how prof you are, how are you? And you cannot say, you stand up, you are cleaner, go away. You cannot tell him. He will also talk with you, he will also eat with you. And emotionally it should be very good in laparoscopy. Daniel Goleman has written one emotional intelligence book. It is freely available and you can buy this or you can download it from internet. And it's a very good book written to how to improve your quality of life and progress by the emotional intelligence. Do you know IQ is only the tip of the iceberg, which you are saying main progress is due to emotional intelligence. Even if you remember your MBBS classes, you will see that all the toppers are somewhere in mediocre stage, and all the backbenchers who are socially good, they are somewhere in good place and they are making more money. All the students who were behind the girls and at the time of college they were considered as a stupid fellow, if you see right now they are much better doing than the toppers. Reason is why? Because emotionally they were already intelligent, they were applying their intelligence at wrong place. But once they start coming in the practice, now they are good and they have developed their skills. So always in laparoscopy is a skill, it's not a specialization. That's why emotional intelligence is important, especially in healthcare and especially in laparoscopy is more important. Because IQ will give you only numbers and digits. Why should I know digit? Google will tell me. But emotional intelligence, even artificial intelligence cannot develop. This is your insight which you should develop. After that, risk factor of the iatrogenic injury. Patient risk factor and the surgeon risk factor. Patient risk factor is previous surgery, adhesion, obesity and difficult anatomy. These are patient risk factor where we cannot help. Because patient has bad anatomy, patient has some variation in anatomy, very difficult, and that's why something perforated or some injury happened. But we can help ourselves. And do you know what is the most important surgeon's risk factor is? Misinterpretation of anatomy. Inexperience, learning curve, misuse of energy, and some do not have attribute for necessary for laparoscopy. These are secondary. But most important is misinterpretation of anatomy. What you are seeing is not correct. Why? Because of optical illusion. Laparoscopic psychological study has shown that surgeons operate on image rather than reality. And visual psychological study has shown that surgeons work on a snap interpretation by brain. Snap interpretation by brain. And success and disaster depends where a snap is right or a snap is wrong. If a snap is wrong, you are bound to go in the wrong. Why? Because of optical illusion. There are a lot of optical illusion happening in laparoscopy, and that creates a big complication. Like I will show you, in open there is only we are seeing the relative anatomy. In laparoscopy there is no role of relative anatomy, you should see the absolute anatomy up to the point of absolute certainty, otherwise optical illusion develops. What are that? Like see, in this picture, this is not a video, this is a picture. There is no any play and pause button. And you can see in this picture optical illusion is happening. It looks like this ring is coming from one eye, ringing in another eye. Exactly same way and it is just due to contrast. Contrast is made in such a way that it creates optical illusion, and you will think that it is moving. It's not moving, it's a static object. And why? Because of contrast changes, it is moving. So exactly same way, sometimes without bleeding we see glare, and sometimes glare looks like bleeding and wrongly we coagulate. Again I will show you, this is also example of optical illusion. In this picture there are 100 pictures. There is a girl, there is a peacock, there is a motorcycle, there is a handle, there is a guitar, there is a finger. 100 pictures are there. And all looks like moving because these all are example of optical illusion. So in laparoscopy is not a surgery in reality. It's a surgery over image. And due to that image, optical illusions are making. These all are optical. Even not human, even animal get distracted by optical illusion. Like see these dogs. There is nothing there. This is just a painting on the wall, painting on the floor, and optical illusion happens, and dogs are restless that how to go there. This is nothing, this is just a flat mattress. There is a flat mattress which is kept over the floor, and then they are jumping because they think that it is there inside. So this type of optical illusion also happen in laparoscopy. So you have to see your anatomy up to the point of absolute certainty, otherwise it will happen. Most common bad habits: confident entry and exit. You should never enter inside without seeing pathway of entry and exit. Otherwise one day we will perforate. Overshooting. Your tip of the instrument should never go 2 centimeters beyond the point of entry, otherwise you will perforate. Ignorance of assistant port. Suppose assistant is holding Mama screw or holding the fundus, time to time you should see, otherwise he will go and he will perforate. Less irrigation and suction. This is also bad habit. Whenever you have a bleeding, whenever you have a misinterpretation of anatomy, you should proper irrigation and suction, and then you consider next step. Ignorance of final inspection. At the end of the surgery, you should have a complete 360 degree all around final inspection. So suppose somewhere inferior epigastric is injured and hematoma is forming, or bowel was perforated, fecal matter is discharging, or you were doing the gynae surgery and there was a lot of blood collected in Morrison's pouch, then you can suck. Just like when you go out of your house for vacation, you are checking that AC is off or not, fridge is off or not, toilet, all the tapes are, otherwise you come back and it is flooded. High pressure of pneumoperitoneum is another bad habit. We should never go more than 15 millimeter of mercury. Do you know some surgeons have a so bad habit that when bleeding has started in myomectomy or bleeding has started in cholecystectomy, they increase the pressure. Do you know why? Bleeding stops. Because as soon as they increase the pressure, due to the pressure of the CO2, capillary bleeding stops. It's an extremely bad habit, because that will stop but air embolism will develop. When the iliac vein, one of the surgeon, very renowned surgeon, iliac vein was injured, he has increased the pressure and repairing the iliac vein. By the time he repaired, already air embolism has occurred. So you cannot do high pressure of pneumoperitoneum. And less blunt dissection is a bad habit. Only use sharp dissection to cut the peritoneum. After that, even in hernia, you separate sac, blunt dissection. Cholecystectomy, blunt. In separation of bladder, in hysterectomy, blunt. So try to do more blunt. So these are most common bad habits which can lead to error, which we try to minimize. Here we can see this is a bad habit. Surgeon, first I will show you and then I will ask you questions. अब देखिए यहाँ पर 2-3 क्वेश्चन है, आई एम आस्किंग यू. इट्स Now I have a question from you. Many questions exist here. One question, what should we do now? Second question, that what type of injury it is. Third question, that why it has occurred. Tell me. First is that it is not a thermal injury. It's a electrical injury. Most of the time we don't know what is thermal injury, what is electrical injury. What is thermal injury? I will tell you. If you were touching here, and then you touch the instrument, bowel, that is called thermal injury. Nothing is required. Even if it is white, no problem. It will never go deeper than serosa. It is heat which has touched. Another this is called electrical injury. Well, I am touching. Simultaneously, when the other tissue was touched, it was active. That is called electrical injury. In electrical injury, it looks white, but it is a full depth injury, because here electrons are passing through that tissue. And then even if it looks white, it never works. You must completely cut and repair. So this is very important that you should be able to interfere between. So ये electrical injury है. This is electrical injury, and that will take full depth injury, and it will be a big problem. Why it is happening? Because two people are working together. इधर से ये हटा रहे हैं, उधर से वो कर रहे हैं. 4, 5, and see, it is touched. And at that time, this is electrical injury. Now I will take a little forward fast. You have to cut it and then suture it. और उसको काट के you have to suture it completely. Bowel injury. Bowel injury is the most common injury in laparoscopic surgery, and most of the bowel injury will be through and through. Here you can see this is through and through. Coming from one side, most of the trocar which has injured the bowel, always consider other side. It won't be only one side. Most of them will go either side in a small bowel. And we can see this is immediately suck the bile. Here it was a bowel injury, and it is leaking, and the bile will be sucked. Why it is sucked? Because patient is fasting, so generally jejunum will be injured most commonly, so it won't have the food matter, but bile will be there. So bile should be sucked because it can create biliary peritonitis. After that, you should suture 2 layers. First layer is full thickness, taking 1 centimeter lateral to the margin. So if you how to do, suppose this is the perforation. This is the perforation. You have to take a bite 1 centimeter lateral to the margin. So this is out to in and in to out. Out to in and in to out. 1 centimeter lateral to the margin always. And out to in and in to out. Full thickness bite. If it is 5 mm perforation, only 1. In 10 mm 2. Don't be panic about perforation. You will perforate one day or another. But don't worry. Again out to in or in to out. Full thickness. Remember, this is contaminated class 1 type of wound, which is not, it is an injury. It's not a pathological perforation. So once you repair then and there, you can continue whatever surgery you were planning to do, except hernia, where mesh is used, so it is not allowed to continue. Otherwise, hysterectomy, salpingo-oophorectomy, appendectomy, cholecystectomy, you can continue. Full thickness bite, out to in to out. Full thickness. And after that, once it is closed, then again second layer seromuscular. After that, second layer seromuscular, and seromuscular should be taken again 1 centimeter lateral to the margin, full thickness, seromuscular, to muff the first layer. First layer should be muffed inside, buried inside in the second layer. And that's all. After that, you continue whatever surgery you are planning to do without any problem, you can continue. So this is how to repair is more important. Of course, if you will do proper task analysis, proper guarding, proper pointing the finger, proper rotation and proper ergonomics, then it will not happen. But it can happen in spite of that. So it should, again other side also you will repair. So this is just 2 layers. First layer is full thickness and second layer is burying the first layer. You can use Vicryl 20 or PDS. Sometimes barb suture also people are using, but even if you are using barb suture, now this is second complication. Here you can see that there is a myomectomy surgery, and surgeon is cutting. This is a very simple myoma which is cut by the harmonic, and harmonic is cutting this myoma from uterus. And one mistake is happening, that vibrating jaw of harmonic should always be under vision. But that mistake didn't turn any complication, that was okay. Always keep Teflon jaw behind the bowel. Vibrating jaw should not be cut like that. It can, thermal injury can happen because harmonic is hot when it is using 80 degrees centigrade. But that was okay, it didn't create, a mistake is there, this is mistake. But without, it is near message, it was saved by the God. Another mistake, he is cutting with the monopolar. Remember, any tissue which is detached from its original attachment, you should never ever use any current to cut. Because right now current is restless to go somewhere, and it is called direct coupling. Immediately current will jump in the air and it will touch. So here surgeon is trying to cut this fibroid by the hook. It is a disaster, it's a big problem, big complication. And see, current is touching and here it is burning. And see, it is burned again. Why? Because it doesn't have its original attachment. It is hanging in the air. So how current will return to the patient return plate? And current monopolar is required to cut because bipolar doesn't cut. So he is cutting with the monopolar hook, and this monopolar hook is burning the bowel. So this is also a big mistake, and video was recorded. So this marking is done after surgery, not during surgery. Surgeon is unaware of that, because that video was identified later, and because video was there, that's why mistake was pointed out. And this is a very bad habit of cutting. You can cut mechanically by Morse letter. You can cut with the endo knife. With the endo knife you can split in two half, but you are not allowed to use any current to do that. This is a big mistake. Now I will tell you later. What happened later? Later, this is a stage of after 2 days. See, after 2 days what happened? Everywhere there is peritonitis. This is uterus. From here the myoma was cut, and everywhere fecal matter, fibrinous exudate, and this is all peritonitis. And after that it was sutured, and then ileostomy was performed, and thorough lavage was performed, and then patient will have septicemia and other problem. So this happened because this is also what? Electrical injury. Electrical injury will never go superficial. Thermal injury means what? Your cup of coffee is hot and you touch by finger. That is called thermal injury. You will get only a skin burn. But cup is still and it has a current, it is on the electric stove and current, and you touch, it will go up to bone. Because it will be a part of your body. Current will go in the earth through your body. Am I right? How you get current? Because you become a part of circuit. Electric current, why you get? Because you become a part of circuit. Current is going through you to the earth. So because current is going through you to the earth, so it is passing through your entire body, and then it will go to the bone. So thermal injury, don't confuse by electrical injury. Many professors are also talking about thermal injury. Thermal injury is not a problem at all. Problem is electrical injury, full burn thickness. Again, this is another complication where bowel was perforated and it was repaired. Here it is repaired. Now this is again another complication where sigmoid colon was perforated here, and this is the bowel which is getting, and this is sigmoid is perforated by putting in trocar, and we can see here a lot of fluid is leaked, and here is the perforation of sigmoid. So what to do? So endo stitch layout. So in those situations, you can immediately first you put a suction inside the sigmoid, and remember, even colon, if it is mechanically perforated, doesn't require colostomy. If you can do full thickness, colostomy is only required if it is identified post-operatively. If intraoperatively identified, then you can do primary repair, and then nil orally post-operatively. But if suppose 2-3 day, third day, first B bleeding, second B bile bladder, third B is bowel. So third day patient comes, at that time peritonitis has already occurred, then you have to do colostomy. But here it is recognized intraoperatively, so no problem. Just you can catch it by atraumatic grasper, push a atraumatic grasper inside to find out that how deep and if the another wall is also perforated or not. And after that you can repair taking 1 centimeter lateral to the margin, full thickness, interrupted suture, and after that muffing it. For muffing sometime epiploics can be used. Here 1 centimeter lateral to the margin, full thickness out to in and in to out, bite is taken with the 2-0 vicryl. So I will take a little forward. So it is done, and after that this is second layer, and then this is muffing. For muffing you may use surrounding epiploics also. So it is same, it is a small bowel, large bowel, doesn't matter. First layer interrupted, full thickness, and then seromuscular to muff it. Sometime if you have surrounding fat, those are called epiploics. Those fats also can be used for muffing, and then this is second layer, and ultimately you can see it is done. And it is nicely repaired, and then you do whatever surgery you were dying to do. Only any prosthesis should not be used, mesh should not be applied, and then it is done. After that here again one trocar was introduced and it is nicely perforated. See here where was the perforation, and this was here, this is liver, this is right lobe of liver, left lobe of liver, and here it was perforated. Where it is perforated? This is perforated here, duodenum is perforated. So one fan detector was used, and this is called auto suturing device. This is auto suturing device. This is called endo stitch. This device is a disposable device to do the bowel repair. It has a needle which swap in between the jaw, and you can do like that and it will swap in between the jaw. So this is called endo stitch. This device is very good and it is handheld, like a handheld shaving machine. So see carefully this device, you will see needle is swapping in between the jaw. This is barb suture, so there is a loop. You don't have to tie even a starter knot. So you can forget all the suturing knotting which you have learned, and after that this endo stitch can be used. So this is the bite is taken, again this needle will swap from right to left and again swapping from left to right, and that way you can take a bite and you can repair it. And as it is a barb suture, so at the end you don't have to terminate because it is unidirectional, and at the end you can directly cut. So this way if you want, then after perforation you can use this type of, and it is done. It's barb suture and it is done. So this way different type of bowel injury can happen. Now coming to the bladder injury. Bladder injury is also very common in gynae practices, and mostly it happens due to the sharp dissection. Already during TLH to the gynecologist I have shown you, and we can see here this is the shearer. Shearer has an advantage that it is a multi-use instrument. Multi-use, so people are using more. Shearer is basically cutting by the high frequency. So here Foley's, this is Foley's catheter is found. So now why it happened? One mistake is that your instrument is parallel to the uterus. Another mistake is it's not a blunt dissection, remember. Third mistake is colpotomizer is not pushing the vagina, colpotomizer is pushing the bladder. Remember, that's why appropriate size of the colpotomizer is required. Otherwise ये bladder को push कर रहा है, and once it is pushing the bladder, here is the colpotomizer pushing the bladder, it should push here, and if you oversize colpotomizer it will do the mistake. Oversized colpotomizer will perforate the bladder and it will also cut the vaginal part of uterosacral ligament. There will be valve prolapse chances also. So whenever it happens, immediately stop, and first thing what to do is to repair the bladder, because once you did the hysterectomy, after repair won't be possible. And here also similarly like the bowel, you should do first layer full thickness and after that muffing the first layer with the seromuscular. So this is immediately you will repair, put a Foley's catheter for 2 weeks. After that there will be, even patient will not notice also. So these type of injuries are not so uncommon. It is happening infrequently, and you cannot say that I will not do, you will also do one day. But immediately you should try to repair then and there, then patient will not notice also. So I will take little forward and it is slowly it is repaired and it is done. Now this is the other case where seizures is used to separate the bladder. This is even more difficult, and here myoma screw was used, colpotomizer was not used, and colpotomizer, if it is not used, only myoma screw is used, then it is must that you should do blunt dissection. Here two surgeons are performing together, and if two people perform together, then the chance of mistake is more, because if you are doing ambidextrity, your left hand is holding and right is pushing, then your brain can synchronize, because your amygdala and hippocampus works together in synchronization. But if two people are performing together, it cannot, and then it is waiting to happen. So this is almost paper thin now bladder, and now again this seizures is about to open the bladder. So these type of, and here one more problem, that some people they put seizures in suprapubic port, and suprapubic port has a problem that your elevation angle will be 90 degree, and with the 90 degree elevation angle blunt dissection is not possible. For any blunt dissection you must be 30 degree elevation angle. 90 degree cannot never do the blunt dissection. 90 degree can never do blunt dissection, it will always do perforation. So that's why it is already perforated, and now I am taking a little forward and see it is second plane and then it was repaired. So this type of injury, if it happens, immediately you should recognize and repair it. If you could not recognize it, no worry, put a Foley's catheter and put the methylene blue diluted saline, fill up the Foley's, and then you will be able to find out the place where it is perforating. Alternatively, you can do cystoscopy also. Every gynecologist should have the privilege of doing cystoscopy. It is not a difficult procedure, just very small learning curve of cystoscopy is there. And why it is required? So that you can put ICG in the ureter, or you can put infrared ureteric catheter. And even surgeons should also must know how to do cystoscopy if they want to do colorectal procedure, or they want to do the any surgery of pelvis in the female patient, then it is required. So it is repairing slowly, and then it is second layer. Now this is again another video where surgeon is separating the bladder with harmonic, and here also bulge of the colpotomizer was wrongly placed, and this is a just about, it is a previous multiple cesarean section and trying to separate, and it is about to open the bladder. So it is just cutting, and then lateral window should form, and after lateral window you should separate the blunt dissection. So only sharp dissection, here it is already opened, and this is the cavity opened. So in those situations you have to make the other plane, and then sometime you may turn it to supracervical hysterectomy, and then you can repair it. So these type of different type of complications are there. These all videos are there in your member area, which you can download and you can see those videos. Now uterine perforation. Remember, if you are doing myomectomy or adenomyosis, remember, never push the myoma screw through the uterine manipulator tip, should not be used, because it will perforate. And although perforation is not a big deal, you can repair it, but problem is if basal layer will be injured, after that severe Asherman syndrome can happen. So in anterior wall myoma, you don't need any uterine manipulator, only it is required in posterior cervical myoma, otherwise it may perforate. And that's why I told you tip of the uterine manipulator tip should always be 2 centimeters smaller than the cavity size, even if you are using uterine manipulator, because purpose of this is not to give antiversion, purpose is only to give the contralateral traction. The cranial traction is given by colpotomizer. So this type also can happen. Conversion psychology, there are two type of conversion. One is elective conversion, other is enforced conversion. Elective conversion means trial dissection for 20 minutes. And if you see surgery is not progressing, lack of progress is time to convert. This is a standard rule of every surgery. Lack of progress is time to convert. Like suppose completely frozen pelvis, completely frozen calottes, completely bad anatomy, and you feel up to 20 minutes you can do trial dissection, and you see that surgery is not progressing, then convert. Enforced conversion means surgeon has to convert, because unfortunately something bad happened, like bladder opened, ureter opened, rectum open, then I have to convert. This is called enforced conversion. Enforced conversion is considered as a medical negligence. Enforced conversion is not allowed. Only elective conversion is allowed. Elective conversion means judicial decision, your decision. And remember, conversion should never be considered as a failure of surgeon. It's a part of surgery. It's a good surgeon, they do more conversion. Don't think that you are converting, that means you are not good. Always it's a good decision in the benefit of the patient. Enforced conversion is a bad decision. Surgeon has to convert, and it can create marked increase in morbidity as well as mortality. Fatigue psychology. Laparoscopy is cerebrally 3 times more intensive compared to open. So suppose I have a 5 surgery today, then do laparoscopy first. Suppose you have cesarean and one MTP and one laparoscopic hysterectomy. Then hysterectomy is the number 1 because you need cognitive, you need fresh brain and you need fresh muscles. In open surgery, it is not a cognitive surgery, so it is cerebrally 3 times more intensive. Degradation of eyeball fixation is one big problem. If your camera person is giving jerky movement, then your eyeball will do jerky movement, and then your judgment and dexterity will be affected. So always use a camera person who can give you a steady camera, and for that all the pelvic surgery camera person should hold telescope in left hand, and for upper abdominal camera person should hold telescope in right hand. If arm of the camera person is not touching the body of the camera person, then there will be jerky movement. So arm of the camera person always should touch the body of the camera person. ऐसे टच होना चाहिए, then stability will be there. If it is little bit abducted, then it will be jerky movement, and this jerky movement will create not a problem of the jerky of, it will be eyeball degradation. Your eyeball will become jerky, and then your judgment and dexterity will be affected. So you must, in movie making, when they make the movie, professional movie, most expensive part is steadiness of camera. That is the most expensive part of the camera. Like suppose you will tell them to take a snap of this room, they will put a rail first. And they put a tripod on rail and they move slowly from this corner to this corner. They don't randomly hold the camera in the hand and they do like that. This we do as an amateur, but professional will not do like that. They use drone, they use crane to take a snapshots. So that's why their picture is so good. So similarly in laparoscopy, camera person is your eye, so he should never give jerky movement, steady movement is required. Golden period of laparoscopy is 45 to 90 minutes. That is necessary. After every 90 minutes you should have a strategic rest break of 10 minutes. There was one of my very good consultant in Imperial College London. He was a very good surgeon. I will not tell his name, but he was a chain smoker, so half of the surgery he was using to smoke. So he trained in Japan, and after that he was very good onco surgeon, gastric cancer surgeon. So in gastric cancer surgery, one surgery takes 6 to 8 hours because it has a abdominal component, then thoracic component for pull through or mobilization of esophagus, and then in the neck also they have to do anastomosis in esophageal cancer and everywhere. So after every 1 hour he used to leave the patient and going to the smoking zone in the NHS where glass chamber, and they smoke and come back. So he was doing like that, and smoking was not allowed, so nurse has complained. After that written explanation was asked that why are you leaving the patient under anesthesia and then smoking, going to smoke. So he has collected all the article published in the strategic rest break in the laparoscopy. If you will type strategic rest break in laparoscopy, then there are many articles published where they recommend that in bigger surgery these all are strategic rest break. After 90 minutes you should do a strategic rest break, strategic rest break, strategic rest break. All is published data, strategic rest break, strategic rest break, strategic rest break. Why a strategic rest break? A strategic rest break is not for you to smoke, a strategic rest break for patient. Because within 90 minutes a lot of hemodynamic alteration happen to the patient. Why? EtCO2 increases, hypercarbia increases, cerebral artery dilates, renal perfusion decreases, urine output decreases, microatelectasis started in the lung, means terminal lung collapses, DVT slowly started, air embolus started forming, and these all will decrease or become zero if you will leave the patient for 5 minutes after every 90 minutes. What to do? You deflate the abdomen. Urine output, you will see within 5 minutes 100 ml urine output increases because renal perfusion become good. EtCO2 was 30, it will become 15. You will see the cerebral artery fine, lung fully, tidal volume increases, minute volume increases, cardiac output increases, venous return increases, and all the CO2 washed out. And again patient is ready to tolerate the trauma of CO2 again for 90 minutes. So for all the bigger surgery, strategic rest break, golden period is 90 minutes. After that, strategic rest break for 10 minutes. And within this 10 minutes, patient will resuscitate and again he can tolerate. And within that time you can also have some coffee and you will also come and you will feel better because your muscles are good, and then you can do faster. All the time which you have spent, you can regain by doing fast surgery. It is not for simple surgery like you are doing cholecystectomy and gallbladder was just about to come out and tang and stop. Because this 90 minutes is over. Because within 5 minutes you might have taken it out. So it is not required. But suppose you are doing multiple fibroid. One fibroid was broad ligament, another is posterior cervical. Broad ligament fibroid itself has taken 90 minutes. Now have a break. Or you were doing bilateral hernia. One-sided you did it dissection, already 90 minutes. Then you should have a strategic rest break. Or colorectal. Or you are doing the oncosurgery. Then in those situations it is important to do rest break. Operating DO. Sometimes you can execute your task simultaneously, two surgeons can perform together. Especially if you have not started those surgery, like suppose you are doing the cholecystectomy but fundoplication you are not doing. You are doing hernia but colorectal you are not doing. Then in those situations operating duo means you can call someone who is performing that surgery, operate with him and execute your task together. I will do that much, you do that much, and then slowly you can develop, because slowly number of cases, number of surgery you have to improve. Means repertoire, your more list should be bigger, and that list you have to add the new surgery. So in that operating DO will help. You have to operate with someone who is already regularly performing that surgery. After that stop calling him and then you start doing yourself. So this is two surgeons can share the execution of the procedure simultaneously. Then self-assessment. Always define inter-step and intra-step. Like without doing task analysis, don't go in OT. Like suppose you have to must written task analysis of every surgery and execution up to the point of absolute certainty. Like suppose you are going to sleep and you are not getting sleep and you are on the bed, then start operating and start analyzing your task analysis. By closed eye, that patient is coming, I am draping, putting one port to breast needle, then one port here, then you try and manipulate, I am putting like that. Slowly, each and every step try to do, because it is a cognitive surgery and all the steps must be programmed inside your brain. Then only you can execute. Just like I am telling dance or singing, it is first, it is in brain. So always define component steps of the surgery. If it is not defined inside your brain, you are not allowed to touch the patient. First you do learn the task analysis and then you do the surgery. Otherwise take your time to see the video and make your own task analysis. In the Google if you will type also task analysis, even ChatGPT may be, agar aap type karenge in the task analysis, they will give you. And it is possible to get those task analysis and further improve that task. I will take one class of ChatGPT also in diploma. Said give me task analysis of TLH. ये आपको दे देगा task analysis. पूरा TLH का task analysis आपको दे देगा, and it will give you all the steps. Step 1 process assessment, step 2 this, step 3 that, step 4 that, preoperative testing that, patient positioning that, operative planning that, the intraoperative phase that, anesthesia that, patient positioning that, abdominal access ऐसे करे. Each and every step, surgical procedure, what are the procedure, each and every step it will give you task analysis to you. And because it is more intelligent than you, and it know all the task analysis. But you can get, this will give you broad task analysis, but this will give you only procedural step. इसमें आपको executional step, you can give all executional step, give all executional steps also. तो ये आपको और broad बना के देगा. Give the executional steps अब फिर से बनाएगा ये, and then it will give you all the executional steps also, and then you can do the further, means all dorsal lithotomy, tilting, varus needle, each and every step of varus needle, how to put trocar, how to put primary, how to put secondary. This is giving all the uterine manipulator how to do, and this is the dissection of vessel how to do, how to coagulate the upper pedicle, how to go uterine artery, how to go separation of uterus, how to do colpotomy, and they can give you, and then closure of the vaginal cuff, and after that, and then you can make your own. So each and every step should be finely defined, all the component steps of the surgery, because without task analysis, laparoscopy is not possible to perform. Now, improve your ergonomics as much as possible, like increasing the OT table height, using the platform to stand, putting the monitor, everything. Analyze your video for error identification. You did surgery was fantastic. Post-operatively, always take a video, put a video in your laptop, take a pen and pencil and identify your own error. Entry without seeing pathway of entry and exit 2 times. Less blunt dissection 1 time, overcooking 2 times, undercooking 3 times, dry tissue 4 times, smoke generation 1 time, dry tissue bubbling was not there 1 time, bad camera person 2 times, call the camera person, what are you doing, see this, call the camera person, because he will deny without video. But once you will show your video, he will, madam, at that time you were pushing my hand. Pushing my hand, why I will push my hand? Your hand was touching. That's why I could not show you properly. Then tell which hand you were holding, right hand. Why? Use left hand, and then next time he will be careful. Whatever mistake you will identify in next video, that mistake will not happen. Why? It will be registered to your unconscious brain, and then it will keep on helping you. Just like any mistake, any road which you go and you see that this road is defective, next time when you go car, you will automatically slow. That aage gadda hai. In front there is a bad road. Or you know, mistake only can happen 1 time if you analyze your mistake. If you don't analyze and same mistake you are doing every time, then nobody can help you. So analyze your own video for error identification. Give marks to yourself after each operation. 10 out of 10 never give to yourself. Give less marks. Maintain your instrument yourself. If you can maintain your instrument yourself, nothing is better than that. Because it will help you much better, because you will know what is the problem and how your instrument behaves with you. Because every batsman, every musician, they maintain their instrument themselves. A guitarist is coming to perform on the stage, and if you will try to give your guitar to him, he will never take. Even though it may be expensive one, but he will not take. He will say, no, I am happy with mine. Because he is habituated with his guitar. How can he use yours? He doesn't know how it works. A batsman who is going to take a performance on the test match and he will say to change the bat, he will never do that. Otherwise he will be out on 0. Every bat has its own feeling. Different weight, different stroke, different part of the bat has different type of a stroke. So maintain your instrument yourself. Have a break, minimum 45, maximum 90, and keep low threshold of conversion. Remember, ideal conversion rate is 1:50. If someone is converting in 1:50, he is considered as a good surgeon. If conversion rate is less than 1, like 1:100, that means you are bad. Means you are less converting. Then you are considered bad. means you are a risky surgeon. Your conversion rate is not good. You should decrease it. Decrease it means convert more. This is different in our country. If someone is converting, you say, "Arey, to khol deta hai seedhe." He doesn't know, he opens always. But he is safer. So conversion, ideally it is 1:50. If it is less, then you are a bad surgeon. Have a low threshold of conversion always. Converting is a good decision in the benefit of patient. Practice makes the man perfect. So there is practice, practice and practice. There is no any shortcut. Either you practice on the endotrainer or you have to practice on the patient. If you will practice on the patient, it will take more time and it will affect your quality of surgery. And if you will practice offline, it will give you that will reflect during surgery. That reflect every skill. The batsman, they are doing net practice. Singers, they are first singing in bathroom, then they sing in front of friend. The cricketers, everyone practicing offline. So here you have a beauty of laparoscopy to practice offline. Open you cannot practice offline. But thanks to laparoscopy you can practice offline. Errors and disaster should not be more than LARP. LARP means as low as reasonably possible. Error can never be 0. But it should be as low as reasonably possible. That is called LARP. And if you do your own HRA, disaster will never happen. Disaster means ship is sinking and you are helpless. You think that earth should split and your existence should vanish. Why you came on this planet earth? So, because your patient is dying in front of you due to perforation of aorta, and how you will feel like? You will feel like that why you came here. So as low as reasonably. If it is LARP, then it is okay, because mistake everybody will do. Because just a failure is not a mistake. You can never succeed without the risk of failure. Failure is must. Failing is good. You cannot have a voice without the risk of criticism. You cannot have a love without the risk of loss. You must take this risk. And human error can never be 0, but it should be in the LARP region. And those who were sleeping can open their eyes now. It has 2 meanings. Fortunately, nobody is sleeping this time. 2 meaning means, one meaning is already you understood, and another meaning is that if we was not seeing laparoscopy with this eye, then we should open our eyes, because your progress is in your hand. Your progress is not in any other person's hand. Your progress, more you will practice, more you will involve, you will develop. Because overnight it is not possible to become a laparoscopic surgeon. This is your own practice which will make you perfect. And after that it is such an interesting surgery that you will start loving it. And then every surgery you will try to perform by laparoscopy. If you have to convert to open, you will feel, oh, I have to open. And then it will be, sometime maybe after 5 years, you will forget how to open the abdomen. आपको लगेगा वो again, where is the scalpel, where is this? So this will happen. But slowly, once you will start progressing, then the sky is the limit. Our purpose of this training was just to give you the insight how to progress. Any training cannot be 100% complete, and it cannot give you the completely skill level from 1 to 100. But the idea is that once you will start with the correct track and correct way, then definitely sky is the limit. So thank you very much. Is there any question?
Now, how to improve myself or to move from the area of assistant to independent surgeon? Like, for example, cesarean section first, I start to assist, and then to do under supervision.
I will tell you, in the laparoscopy, there is no benefit of assisting other. This is the problem. In open surgery, it's a knowledge. So if you are seeing other how they perform, you will know. Laparoscopy, there is no way. Just like if you are sitting by a side of a seat of a driver for 10 years and see how he is driving the car, very good. He is putting the brake. Now he is pressing the accelerator. Oh, he is changing gear also. You will never drive the car unless until you sit on the driving seat and take a steering in your hand. So you must sit on the steering. Remember, for that it is necessary that you start driving. Remember, performing a diagnostic laparoscopy skin to skin completely yourself has more value rather than assisting someone in radical hysterectomy. Absolutely no value. So try to become a surgeon, and after this training you are eligible also, because you are getting university fellowship, and it will help you medico legally also, and you are eligible, not only eligible, you are trained enough to start laparoscopy. You should start performing the surgery, and slowly, remember, there are society who has given the level of laparoscopic surgeon. In gynae there are 3 levels, level 1, level 2, level 3, level 4. Level 1 is always it is recommended that before one level crossing another, at least 20 surgeries should be over. So initially level 1 for gynae start with diagnostic laparoscopy, tubal patency test, simple adhesiolysis, simple fulguration of endometriosis. This is level 1. And your 20 level 1 must be done. Once, it is not necessary every surgery 20, altogether 20. Once level 1 is finished, this level, just like game when you are playing, level 1, level 2, level 3, same way. Level 1 finished, now you jump to level 2. In level 2 comes the TLH, then the simple myomectomy, then the ovarian cystectomy, dermoid, simple cyst, endometrioma. This is called level 2. After that, jump to level 3. Level 3 comes myomectomy, sacrocolpopexy, butt suspension, pectopexy. These all are called level 3. And severe frozen endometriosis, level 3 endometriosis. Level 4 is institutional surgery, which should not be performed by solo practitioner. Level 4 means radical hysterectomy. And this, why level 4? Because it needs multidisciplinary approach. Am I right? You need radiotherapy, you need chemotherapy, you need multidisciplinary physician, cardiologist, all should be there. So it is not allowed to do in solo. Solo only up to level 3. In tertiary care center is allowed to do level 4. Now, for surgeon, level 1 is coming cholecystectomy, appendectomy. Level 2 comes hernia, all type, inguinal, ventral, rectus divertication, these procedure. Level 3 comes bariatric surgery, fundoplication, Hiller's myotomy, and some of the bariatric surgery. And level 4 and simple colorectal like rectopexy. This level 3 surgery we will discuss during diploma, to gynae also and to surgeon also, and you will do it also. And level 4 again comes radical procedure like low anterior dissection, colorectal sigmoid, gastric cancer, Whipple's procedure. These are again comes in level 4. And level 4 even for surgery is not allowed to do solo. It is only multidisciplinary tertiary care center. So only assisting will not help you, unfortunately. You should must start your own, and start with the level 1, then level 2, then level 3, then level 4. Don't jump directly to higher level before completing the lower level. And that way you will not do accident, and your learning curve also will progress better. Of course, if you are already in level 1, then you should now go to level 2. And you are level 2, then go level 3. But if you are only assisting right now, then first you start doing level 1. For that you have to find out the opportunity where you can start, because as you are from the Saudi or in other country, they have a lot of inhibition restriction, because as a specialist you will not be very much allowed to do independently unless the consultant wants. So this is the problem I can understand. So in those situations you may look for the other hospitals, or you can try to request them to give you at least to do some part of surgery, like trocar and other things, and initial basic dissection, and in the critical part they can take it. Like in, yes?
In UK, because we have many consultants, they are just noted even in UK there is restriction or some deficiency in laparoscopic training. So any specific hospitals they have laparoscopic?
Unfortunately, this is a big problem. This is a big problem that nowhere in the world any consultant will allow you to perform surgery on his patient. You got it? Even in India, even the corporate where paid registrars are there, paid hospital is paying to them, they also is only assisting the consultant. Am I right? Consultant they don't allow. Why? They have 2-3 problems. One problem is that they may not be confident on you. This is one. Second problem is that if they will give you, then hospital will object and the patient also will object. And third is that from the core of his heart, he don't want you to develop. Why should he make his own competitor? So they also don't want. You got my point. So these are the 3 problems, that's why. But in some of the government, like for Indians I will suggest you to municipality hospital like here in Delhi, DMC ka jitna hospital hai, like Hindura Hospital, Raja Harishchandra Hospital and other hospitals, in that they get opportunity. If you will join a specialist job, then you will get opportunity to perform. Even in Mumbai metro cities they have opportunity in government hospital. In corporate hospital, unfortunately, it is not there. And in NHS, the people who go for FRCS, MRCS or anything in UK, and if they are returning back and they are saying that they have done a lot of surgery, they are lying. Am I right? Unless until you are consultant, you will not be allowed to perform entire surgery yourself. Am I right? In registrar level, only port position. Trocar dal ke de do. And they is doing. So in that situation, sometime what you can do that you can request to your consultant, this is the only option. After that, prove themselves with your skill. So suppose sometime if you have opportunity and you can show them your suturing skill, your knowledge, and they will know also while you are operating and assisting, they will know. Because ultimately a skill speaks itself. The way how you are holding the grasper, within 5 minutes to whom you are assisting, he will know your level. Like how you are introducing your instrument. And directly you reach your target and in one attempt you catch, he will understand. Yeah, because skill itself speaks, isn't it? Someone is singing in front of you, then immediately within 2 sentences you will know that he is really a singer or not. So immediately once he will understand that you are a good in a skill, then he will start, faithing on you, and then he will start giving you automatically. You have to keep him in the confidence and then they will start giving you. So unfortunately this path you have to find yourself. Returning to your country and doing in your country is much easier than the UK, as you might have seen, because in UK they have a lot of restriction in the different level where you have to respect their protocol. But don't worry, it will come slowly. So thank you very much.